I'd like to introduce Associate Professor Chris Poulos, who is the Hammond Chair of Positive Ageing from the University of New South Wales, who's going to chair this session.
Thanks very much, Raina. I hope you're all energised. I'm a rehab physician and I have an academic and clinical interest in positive ageing and helping people in older age maintain their functional abilities. It's my pleasure to welcome you to the very first scientific session, and it's my pleasure to welcome back to the podium Professor Raina MacIntyre. Raina is Professor of Infectious Diseases Epidemiology, and she's Head of School of Public Health and the School of Public Health and Community Medicine at the University of New South Wales, and she's Director of the CRE. So, without further ado, I'll invite Raina back to the podium, and she's going to be talking about: is the glass half empty or half full? Changing the paradigm of vaccination for the elderly. Raina.
Thanks, Chris. I'd like to acknowledge the Wurundjeri people of the Kulin Nation and also the National Centre for Immunisation Research, UNSW, and the NHMRC Centre for Research Excellence, as well as our sponsors from industry who are making this event possible, and the sponsorship is listed on the program. Just got these disclosures. So I'd like to start by talking about the ageing of the population. 80% of our population is aged over 15 years, and the median age of our population is 36.8 years. At the top there you see population pyramids, and the classic pyramid shape, or the triangle, is what you see in a developing country. And an example down the bottom there is from Angola, where the bulk of the population is young, and as you get to the older age groups you get fewer and fewer people. In countries like Australia, on the other hand, you see more of the inverted pyramid, with bulging in the middle age groups and the older age groups. And as the population ages, this pattern becomes more and more pronounced. And indeed, this is the trend that we are seeing in Australia. This is the population pyramid for 2013, and you can see that we have an ageing population. Our society is ageing. 14% of our population currently is over 65, but by the year 2056, 1 in every 4 people will be over 65. The number of people aged over 85 will also continue to increase. The chance of being in a nursing home will continue to increase. And the number of people in aged care could rise from about 80,000 now to about 200,000 by 2040. We also know that about 10% of the elderly who are in hospital have a respiratory infection. As Michael already alluded to, acute care consumes over 90% of the healthcare budget, well over 90%, 99%. The ageing of the population and the increased burden of acute health services will increase the drivers for primary prevention and positive ageing. And immunisation is just one in the interventions that we have to assist with positive ageing. But one of the other important issues is the ageing of the workforce, and this graph shows how the workforce has aged from 1967 to 2012. And you can see the proportion of workers aged over 45 has gradually increased in that time, and this trend will only continue. So keeping seniors healthy makes economic sense, not just because we can prevent hospital admissions, but because we will actually increasingly rely on an older workforce to actually sustain the economy, and that's been forecast by economic specialists. There will be older retirement, and this means that the importance of prevention really can't be stressed too much as a means for positive ageing. This is from The Australian recently. You've heard that the pensionable age is going to rise to 70, and of course that's to save money, but it does tie in with this idea of an older workforce and people having to work for longer. Vaccination really is low-hanging fruit for prevention of disease. Vaccines are safe and effective. Influenza and pneumococcal vaccines are provided free for people over 65. But we know that vaccination rates for the free adult vaccines are much lower than they are for free childhood vaccines, 50 to 70% compared to over 90% for every single one of the 12 childhood vaccinations that are provided free. Research also shows that doctor recommendation is the strongest predictor of vaccination. So why don't doctors believe in vaccination for the elderly? This is our current schedule, and also herpes zoster is recommended for people over 60 but not funded. Pneumococcal and influenza vaccines are funded, and there's a tetanus booster recommended at 50 years with DTPA. So there are many challenges to adult vaccination that are different to the challenges of infant vaccination. Unlike infants who are carried along by their mother or father to the GP, adults are a mobile population. There's no easy single access point. They are difficult to target. And we know in Australia that elderly might have multiple GPs, multiple providers. We don't have a universal health record or vaccination register, so it's often hard to track what vaccines elderly people have had. There are significant provider barriers because generally health providers don't have as much confidence in vaccines for the elderly as they do for childhood vaccines. We also have a lack of an evidence base. There are far fewer research studies and clinical trials that include frail elderly people. The vaccines themselves are less immunogenic in the elderly, and we have, with all due respect, we do have a paediatric immunisation culture, and that's natural because immunisation has largely arisen from a paediatric discipline. So the peak advisory bodies are very well represented in paediatrics but less well represented in adult medicine. Adults, however, represent the majority of the population, but we still don't have an adult vaccination register. We don't have an e-health record that's accepted in Australia. There are no champions for adult immunisation and many missed opportunities for vaccinating seniors. This picture here is a really excellent guide to childhood immunisation that we had in those of you who were at the conference in the last couple of days would have seen it in your conference bag. But where's the guide to adult vaccination? This had a nice fridge magnet and everything in there. I'd like a fridge magnet for adult vaccinations. And I'd like to talk a bit about this saying, pneumonia is the old man's friend. We know that demented and frail elderly are less likely than non-demented or less frail elderly to be vaccinated. We know that also the older seniors are less likely to be vaccinated. If you're more than 80, you're less likely to be vaccinated than if you're under 80. We know that nursing home residents and staff in nursing homes are less likely to be vaccinated. And we know that we get explosive, severe outbreaks of infectious diseases in nursing homes that cause illness of residents and staff. How is pneumonia anyone's friend? Communicable diseases impact on more than just the individual. It's not like diabetes or asthma. You know, if one person gets sick, you can transmit it to someone else. There is individual suffering. If anyone's had a family member who's had pneumonia or shingles, they would know there is individual suffering. These nursing home outbreaks have a massive economic impact in that sometimes you've got to actually close the whole nursing home to admissions if there's a large outbreak. And we know that despite being under-vaccinated, demented and frail elderly, once they develop pneumonia, are still transferred straight to hospital. Pneumonia can also cause acute delirium, and delirious patients lose their autonomy, they lose their mental capacity, and seniors become much more vulnerable when they're acutely ill. I'd like to talk briefly on the not for resuscitation dilemma as well, because it links to some of the ethical aspects of withholding information and withholding treatments and prevention from seniors. Now, acute infections are one of the commonest causes of delirium in seniors, and not for resuscitation decisions can be made for seniors in delirium, which is a reversible condition. Once you treat the infection, the delirium is finished. So even seniors and the other point is that even seniors who say while they are well, I don't want to be resuscitated, I just want them to pull the plug, they may well change their minds when they are acutely ill, and that has been shown in research that the decisions people make when they are well can change when they are ill. And in that situation where you have a senior patient who is delirious, they lose their autonomy to their children or to their doctors who make decisions about their resuscitation. And similarly, doctors also may make judgments about the value of prevention and fail to recommend vaccines. to seniors. So I'd like to talk again about what does pneumonia is the old man's friend mean? This is my translation. Old people are a burden and should hurry up and die. Old people have no right to self-determination and autonomy. Old people have no right to prevention or treatment, nor to a healthy life. That's what it means to me. I think there is ageism in healthcare. We do make value judgments as healthcare providers. There are ethical issues about withholding treatment and prevention, and there are ethical issues around withholding information. The commonest reason why elderly people don't get vaccinated for funded vaccines, and research has shown this, they say, but my doctor never told me. So I'd like to talk a bit about the immunological basis of vaccines in the elderly. Immunosenescence is a term that's used to describe the progressive decline of the immune system with age. And we know that there's a wide range of defects in cellular and humoral immunity with ageing. Cell-mediated immunity actually wanes exponentially after the age of 50, and waning immunity makes vaccines less effective in the elderly. So that's a graph showing the relationship of cell-mediated immunity to VZV with age, and you can see age on the x-axis and immunity on the y-axis. There is an exponential decline, and that actually correlates very well to the exponential increase in herpes zoster that you see after 50. So we need research that focuses on improving vaccine immunogenicity in the elderly, whether it be conjugation, adjuvants, routes of administration. And we shouldn't assume that frail elderly can't respond to vaccines. A paper that we've just published, and this analysis was actually Peter MacIntyre's idea, was looking at if you have no OPA to pneumococcal antigens at baseline, so no immunity at baseline, how do you respond compared to people who do have immunity? So the blue line is people who do have immunity to the OPA, detectable OPA at baseline, and the red is people who don't have detectable OPA at baseline for serotype 4. And you can see when you look at on the left-hand side here is ELISA, but we're looking here at the OPA responses. You can see that the people with absent immunity actually mount a pretty good response. They still have a lower final level of antibody than those who had antibody at baseline, but it's not bad. Okay, so you can't say that they don't respond. Now, just going back to the issues at the extremes of age. In babies, the thymus, which produces T cells, doesn't develop fully till 6 months. And until then, we know that babies are more vulnerable to infection and they rely on maternal antibody and on the first doses of vaccination for protection. And the infant immune system matures with age. Each dose of vaccine is given on the background of a progressively strengthening immune system. It's a winning game with big rewards. But many vaccines display waning of immunity over time, even in healthy people. Waning of immunity matters a lot if you've got 80 years of life ahead of you. In the very old, on the other hand, each vaccine is given on the background of progressive decline in the immune system. It's a losing game. It's not as rewarding. But this isn't a reason to deny vaccination to the elderly. It's simply a challenge that requires innovative solutions and a change in perspective. Yes, vaccines do wane faster in the elderly. But does it matter if a vaccine wanes to unacceptably low levels after 10 years if you only have 10 years of life left? I don't think it matters. Waning is not as important in the elderly as it is in infants. We also have significant bias in interpreting and reporting the evidence around vaccines for the elderly. Let me give you some examples of things that I've heard around pneumococcal vaccines. Oh, it's only effective against IPD. Oh, it only protects against vaccine-type pneumonia. Oh, but the efficacy against all-cause pneumonia was low. Have you ever heard anyone say about meningococcal C conjugate, oh, but the efficacy against all-cause meningitis is low? Oh, it only protects against group C? Why is it that we say these things about elderly vaccination? Of course you don't expect it to have efficacy against non-vaccine serotypes. So going on to vaccine efficacy then. Vaccines in children are often more than 90% effective. And vaccinologists think of vaccines as poor if the efficacy starts to drop below 80%, and probably totally unworthy if the vaccine efficacy is less than 60%. Yes, vaccines are less effective in the elderly. But is it appropriate to compare vaccines in the elderly to vaccines in infants? How do vaccines in the elderly compare to other accepted preventive strategies in public health? Let me give you the example of ischemic heart disease. 30 years ago, having a myocardial infarction led to reduced life expectancy. Today, there's been radical innovations in the management of ischemic heart disease, the main one being rapid time from onset of chest pain to getting to a catheter lab, early revascularization, and also things like statins for lipid lowering. People with ischemic heart disease actually usually have a normal life expectancy, and that's a radical breakthrough. Ischemic heart disease is never referred to as the old man's friend. Statins have an efficacy as secondary prevention of approximately 25% and are accepted worldwide as an important and worthwhile public health intervention. In public health, accepted worthy preventive strategies often have efficacies of 25% or even less. Antihypertensives for the treatment of prevention of ischemic heart disease has an even lower efficacy than statins. Vaccines in the elderly actually look fabulous when compared to statins. Pneumococcal vaccine that prevents IPD or vaccine-type pneumonia is good news. A flu vaccine that protects against strains for which it is matched is good news. Efficacy really isn't the be-all and the end-all. It's not the full story. It's only part of the equation, and I'm talking about a different equation to the one Max referred to. Public health benefit equals the burden of disease times the preventive efficacy, or it's a function of burden of disease and preventive efficacy, not just efficacy alone. So you've all seen these graphs. We know with influenza, for example, the burden of disease is highest at the extremes of life, the very young and the very old. Pneumococcal meningitis, septicemia and hospitalisation rates, again, the burden of disease is high at the extremes of life, particularly in the older age groups. Tetanus, burden of disease is highest in the older age groups. Grandparent care. 29% of working mothers have a grandparent providing childcare for their children under 5, and 35% of children have received grandparent care during a 3-month period. Pertussis. So grandparent care does cause a risk to infants, under-vaccinated infants, particularly those under the age of 6 months, but the risk to the elderly is not well recognised. We've actually had 7 documented deaths from pertussis, maybe a few more. Peter might be able to update me on the numbers, but in Australians aged over 65 in recent years. And nursing home outbreaks of pertussis are increasingly documented. And there are the pertussis notification rates in Australia, which have gone up significantly in the older age groups in the last 7 years. Another graph showing the burden of pertussis and the huge right shift of that burden into adults and the elderly. Herpes Zoster, again, you see this is the original Hope Simpson graph, the first person to describe this phenomenon, a British GP, and it shows the exponential rise of incidence of herpes zoster and post-hepatic neuralgia, and almost every study that has looked at this has shown the same trend after the age of 50. And there's a range of other public health benefits of vaccines. There's a large body of evidence that influenza vaccine actually prevents acute myocardial infarction because infection is a likely trigger for acute thrombosis in an already diseased artery. About 10% of patients with acute myocardial infarction have undiagnosed flu at the time of admission. And patients at risk of heart disease are usually under-vaccinated. There's also the cancer prevention vaccines like hepatitis B and HPV, for which the benefits in cancer prevention are seen well into the future when people are adults or older. And then there's the issue of nursing home outbreaks, which can have major health and economic consequences and which can be reduced by vaccination. So that equation again, public health benefit equals burden of disease times preventive efficacy. Just want to put it to the test with one of these graphs that I pulled off the health.gov.au website. This shows invasive pneumococcal disease in 1 quarter of the year. I just quickly added up, the number of cases just by eyeballing it. Did this table here, 0 to 4, 50 to 59, and then I put in the over 65s, the total number of cases of disease, 160, put varying vaccine efficacy here, 70%, 60% down to 30%, and even if you go down to 30%, you're preventing more cases than you do in the 0 to 4. Yes, you've got to vaccinate more people, but it's showing you that the public health benefit is a function of both efficacy and disease burden, and that even a vaccine with lower efficacy can still have public health benefit. So to finish off just by looking at some of the other barriers for vaccination, providers are not a homogeneous group. There are GPs more likely to support elderly vaccination than hospital healthcare workers, and hospital healthcare workers also have problems accessing immunisation information. We don't have a record of vaccination for adults, and there are a range of possibilities of how we could get that kind of a record, maybe through the electronic health record, through GP software, or an Australian immunisation register. We know that doctor recommendation predicts vaccination, even in people with negative perceptions of vaccination. And there's a real lack of the evidence base. There's a systematic exclusion of the frail elderly from RCTs, despite this being the largest growing area of health need. And it's a vicious cycle of lack of evidence, lack of recommendation, lack of protection. The good example being the Zostavax, for which the shingles prevention trial had very small numbers over the age of 79. So there's not statistical power, and there's no recommendation after 79. And there's many barriers to recruiting frail elderly into RCTs, high mortality rates, polypharmacy, multiple medical conditions. What we need is more RCTs that include frail elderly, more cost effectiveness studies, which Tony will talk about, more research on improving the immune response in the elderly, recognition that ageing is the single largest area of healthcare need, a change in perception on the value of preventing illness towards the end of life, and a whole-of-life register should be considered, but I don't think any single measure is enough on its own. I've got a slide here on some special issues around flu vaccine, which I might skip. In terms of closing this gap in adult and childhood immunisation, targeted programs are not that effective, and that's been shown with every targeted program in history. Financial incentives are not tested in adults, but they've been used successfully in infant programs. Public funding does work, both flu and pneumococcal vaccine. The rates went up rapidly after public funding. Education programs have a transient effect, but I think we need a quantum change in healthcare provider perspective. I think we need to think about the ethics and human rights perspective. There are many arguments for healthy ageing: economic, ethical, social and human rights. We should be advocating for equity in disease prevention. Seniors have a right to autonomy, self-determination and informed choices, and they can only make an informed choice if they're told about what vaccines they could avail themselves of. And we need to acknowledge and reflect on ageism and value judgment in healthcare. So I think, to finish off, the glass is half full. Pneumonia is no one's friend. Seniors do have a higher burden of disease and more serious complications. Infections are unique because preventing one infection prevents transmission to others. A vaccine can't protect against something it's not designed to protect against. For example, all-cause pneumonia or all strains of influenza. So don't be so surprised that it doesn't. Vaccine waning doesn't matter as much in the elderly. Vaccines with lower efficacy have public health impact if disease burden is high. And vaccines are more effective in the elderly than many accepted public health interventions. So thank you, and there's a paper in your bag called Vaccination, Elderly Vaccination, the Glass is Half Full, which has all the references that I've mentioned.